Welcome to our presentation, Mental Health for Everyone, Mental Illness for Some. For those of you who are new to CMHRC, welcome. My name is Elizabeth Errico, and I'm the Executive Director and founder of CMHRC, where our mission is to provide guidance and resources for early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype, known as thermoregulatory sleep dysregulation disorder, but commonly dubbed FOH, or fear of harm, for one of its most salient symptoms. Our presentation is going to cover the difference between mental health and mental illness. For those of you who may wish to receive continuing education credits for attending this event, please go to our website where you can register to receive continuing education credits through ASWB. My colleague Angela, who is handling the Q&A and the chat, will be putting the link in there if you would like. If you would like to take this as a recorded course, it will be available next week in our continuing education portal, where you'll be able to find it along with other recorded and reading-based learning opportunities. So let's get started. Our learning objectives for this evening are to identify the difference between mental health and mental illness, to examine the prevalence and impact of mental illness on children and on teens, and to describe the best practices for effective treatment, and finally, to explain a new, more effective approach to parenting that supports parents and caregivers of children living with mental illness. Now, physical health versus physical illness. We're going to start here because understanding the difference between mental health and mental illness can be complex and confusing, but less so with physical health and physical illness. And so by starting here, we can begin to understand a baseline of what we're talking about. Now, physical health can be described as a state of well-being, or a state of being where internal and external body parts, organs, tissues, and cells can function properly, or as they're supposed to function. We all have physical health, and we experience variable states of physical health. For example, it can be challenged by external factors, such as having a cold or the flu, or temporary injuries like a broken bone or an ear infection. After physical health challenges are resolved, we return to baseline. Oftentimes, no intervention is even necessary. We're able to make the recovery from this blip without the intervention of a physician or any sort of direct treatment. Now, physical illness, on the other hand, not everybody experiences a chronic physical illness. In a chronic physical illness, the baseline of our health includes that chronic state of illness. It includes involuntary symptoms, which can cause subjective distress or impair functioning. Examples of this would include things like diabetes, asthma, heart disease, muscular dystrophy, certain kinds of cancers, and more. With these illnesses, intervention is required. Treatment is necessary to maintain diabetes, to maintain breathing in the cases of asthma. The intervention is a manageable part of life that is integrated into daily life in order to maintain the best possible state of health in the presence of the illness. Now, let's take a look now at comparing physical health to mental health so that we can understand the differences there. Physical health, as we said, is this sort of chronic state of being that we all have that is the sort of optimal functioning for our bodies, whatever that optimal functioning may be for an individual. It can again be challenged by external factors such as a cold or a flu and that sort of thing. After the challenge has passed, we return to baseline. Now, the same here is true for mental health. Mental health is a state of well-being when our mental, emotional, and psychological factors are all functioning properly or as they are supposed to function. And just like physical health, we all have mental health. We all experience variable states of mental health that can be challenged by external factors, such as loss, environmental changes, relationships, changes in our lives, such as moving or changing jobs, or any sort of the stressful events that we live through as human beings. But after mental health challenges are past, just like with physical health, we then return to baseline. Physical illness versus mental illness now. So with physical illness, as we discussed, not everyone is going to experience a state of chronic physical illness. But for someone who does, their baseline health includes some chronic state of illness. Its symptoms are involuntary. They are causing subjective distress. They may impair functioning, such as with asthma, diabetes, and the other illnesses listed here. When we have one of these illnesses, we have to make accommodations for activities that we do, the way we take our medications, the way we manage our therapies, because having this chronic illness is a part of our daily lives, requiring both intervention as well as management. Mental illness is the same. Not everyone experiences chronic mental illness. But for those who do, their baseline of functioning includes that chronic state of illness. Mental illness, just like physical illness, has symptoms that are involuntary, that cause the individual subjective distress and can impair day-to-day functioning. Examples of this include things like major depressive disorder, generalized anxiety disorder, ADHD or OCD, schizophrenia, and more. In the case of chronic mental illness, intervention and management is required in order to maintain that baseline that includes chronic illness. Now, we can put all of this together and look at mental health versus mental illness on the surface, and then we'll get into it in a little more detail. So mental health, a state of well-being, when mental, emotional, and psychological factors are functioning the way they're supposed to. And yes, we all have mental health. We all experience variable states of mental health, and it can be challenged based on what is going on in our lives from day to day. But after specific mental health challenges have been met and overcome, we return to baseline, often without needing intervention. Mental illness, on the other hand, is not experienced by everyone. It has a baseline of health that includes that chronic illness and includes involuntary symptoms that cannot be controlled by the individual without assistance and support, such as interventions of medication, therapy, and lifestyle interventions. But it is important to remember that just like with asthma and diabetes, with mental illness, those chronic states of illness can be managed to improve and maximize daily functioning and quality of life. Now, we're going to look here at an example of one such disorder that is listed in the Diagnostic and Statistical Manual of Mental Disorders, known as the DSM, but that doesn't mean it is an illness, and it's called an adjustment disorder. So, with an adjustment disorder, it is basically what it sounds like. It's about difficulty adjusting to something that is happening as a normal part of everyday life. Now, just because something is normal and expected doesn't mean we might not have struggles related to it. So, importantly, an adjustment disorder has an identifiable stressor that triggers its onset, and that once that external factor has been resolved, the person returns to baseline. So this is a disorder that is identified in the DSM, but is basically a normal expected part of human experience. It is, by its very definition, not a chronic illness. It is a mental health challenge, much the way getting the flu or a cold is a physical health challenge. We are able to overcome it and return to a baseline free of illness. Now, mental illnesses are different. Mental illnesses are chronic conditions that can, and these are some examples: major depressive disorder, generalized anxiety disorder, bipolar disorder, schizophrenia, disruptive mood dysregulation disorder, post-traumatic stress disorder, borderline personality disorder, obsessive compulsive disorder, attention deficit hyperactivity disorder, and many more. There's sometimes a misconception that these types of illnesses can only happen in the adult population, but it's not the case. In fact, all of these disorders can exist and be present in children and adolescents. So, what's the difference here? With mental health, while we're experiencing some form of distress, the individual is likely capable of learning new skills, putting those skills into practice, and through the use of those skills, send the symptoms that they're experiencing into remission. Mental illness, on the other hand, experiences involuntary symptoms that the individual cannot control. And as a result, when they are in the throes of a symptomatic episode, they are not most likely going to be able to learn new skills or to put those skills into practice. And they will likely be unable to access and use skills that they had previously learned. This is, in fact, one of the main obstacles to therapy interventions, such as cognitive behavioral therapy, which focus on the learning of skills, the ability to implement them during times of stress, all of which is absolutely possible while experiencing a mental health challenge, but often is not possible at all during an episode of symptoms from a mental illness, because those symptoms are involuntary and they block the brain's ability to process, practice, and put into effect skills that are being learned cognitively. Now, there is often, unfortunately, a false equivalence that occurs when we're talking about mental health and mental illness. And to some degree, this has been done as a way of sugarcoating the effects of psychiatric conditions. So, for example, There are pros associated with downplaying the fact that someone is living with a mental illness. It can reduce stigma and promote acceptance. We might have a better chance of getting our children's teachers and friends and coaches and aunts and uncles to accept them if we just say, they're a quirky kid or they're a complex kid, and sort of let it go at that. It can reduce stigma, promote acceptance amongst the community if we're not going around with labels like schizophrenia, bipolar disorder, major depression. The pros of this equivalence of referring to mental illnesses as mental health problems also can improve access to certain treatments and modalities, such as cognitive behavioral therapy. Referring to something as a mental health challenge that can be addressed through cognitive and behavioral skills is a positive thing because it allows people who might not otherwise have access to this treatment access. And it also introduces the idea of mental health challenges in a very non-threatening way. It allows people to recognize that mental health challenges are, in fact, universal, that everyone has mental health, and that everyone experiences challenges to it from time to time. But there are also cons associated with this false equivalence and this sugarcoating of psychiatric conditions under the umbrella of mental health only. And those cons include that the baseline benchmark that we expect of people is established by and maintained by those who do not live with a mental illness. This is particularly pernicious because one of the things that happens here is that we expect that people who have mental illnesses are going to behave as though they don't have a mental illness. And that is not something that we would expect of someone who is struggling with a physical illness. We wouldn't ask someone with diabetes, type 1 diabetes, to eat something sugary and not take their insulin because regular people don't need to do that. So it becomes problematic when the benchline and baseline for expected and established behaviors is one that is rooted in what those who do not live with mental illness can expect. This false equivalence between mental health and mental illness also reduces the perceived acceptability of medication use and can paint those who choose to take medication to treat their chronic illness as weak or taking an easy way out or being, quote, drugged up, rather than facing these challenges without the support of the medications required to treat the biological illness that underlies. This again would be like telling someone who had asthma that they were not allowed to use an inhaler or even have one. Or if someone who had a deadly peanut allergy wasn't allowed to have an EpiPen because that just meant that they were weak and should be able to overcome their peanut allergy and their peanut exposure through sheer force of will. That leads to the idea that equating mental illness and mental health with one another minimizes the understanding that involuntary symptoms are what people living with mental illness have to contend with. They don't have a say in when their symptoms appear. They don't have a say in whether or not those symptoms are severe or not, because they are not being triggered by any sort of external event. Rather, they're being triggered by something internal, a chemical, neurological, electrical change in the brain that is resulting in changes in how they feel, how they can act, and what they are capable of accomplishing. Additionally, this false equivalent attributes intention and choice to these involuntary symptoms. Involuntary symptoms are, in fact, exactly what they sound like, involuntary. which means that not only does the person not cause those symptoms to occur, but that person can't make those symptoms just disappear because they decide they need to. The other difference and the con associated with equating mental health and mental illness is that it actually limits the therapeutic modalities that people with mental illness have access to. There's an idea that everyone has mental health challenges, so everyone can benefit from the same types of therapies. This is absolutely not true. As I discussed a moment ago, there are certain types of treatments like cognitive behavioral therapy that frame everything as behavioral instead of as an involuntary symptom, and believe that with the right skill development, someone will be able to overcome all of those behaviors. Well, that doesn't work when it's an involuntary behavior that the person doesn't have control over. So people with mental illness need access to different kinds of therapeutic interventions. Frequently, cognitive behavioral therapy and other behavioral therapies like it have limited numbers of sessions that can be paid for through insurance. Someone may have 10 or 12 sessions a year that can be covered, whereas someone living with chronic mental illness will need to engage in therapy most likely all of the year, every year, as a part of a comprehensive treatment plan. So equating mental health challenges with a chronic mental illness it's a disservice to those who have mental illnesses because it can deny them access to the comprehensive treatment that they need. The stigma associated with mental illness is severe and important to acknowledge. As I mentioned, we sometimes downplay mental illness and we portray it as mental health challenges or describe it as mental health challenges because stigma can be both external or internal. And some of those assumptions that are made about people who live with mental illness are that they're violent, they are criminals, that they're dangerous to be around, that they're doomed to having nothing but poor relationship with lots of drama and difficulty, that they may be homeless, institutionalized, zonked out on medications, or that they are experiencing symptoms that are so unmanageable that it is going to impact negatively their ability to have meaningful quality of life and to carry on with their activities of daily living. Now, this can be dangerous for people who are living with mental illness. These stigmas are dangerous because they can significantly impact the way people are able to access life. So, for example, recently we encountered a story on a Facebook community group. This community group was up in arms because there was a community home that was a group home for adults who were living with mental illness. The community was very concerned. Why hadn't they been notified? Weren't their children in danger by having people living with mental illness in the neighborhood? This is absolutely not the case. People who have mental illness have every right to live their lives in the least restrained setting possible, with the most supports that they can have to support them in living a full and meaningful life. Recently, we screened a documentary called Brainstorm, and this documentary is about people living with bipolar disorder. Some of the featured individuals in this documentary included the former Surgeon General of the state of California, a 3-star general in the Army who was decorated extensively for his ability to lead troops and to serve his country abroad in active war zones. These people are absolutely capable of living full, meaningful lives that contribute to our community, our society, and our world at large. And so being able to confront stigma when we recognize it, undo it, is extremely important. This stigma is something that not only can cause damage to people emotionally, but this stigma can also cause damage to people's livelihoods, making it difficult for them to get jobs, making it difficult for them to stay in school. We had a case of a family where the school counselor disclosed to another family this child's diagnosis. And as a result, everyone in the community knew that child wound up not having any friends as a result of the fact that parents were concerned that the 7-year-old was somehow going to be violent just because that child had a mood disorder diagnosis. So we would not ignore the needs of people who were living with cancer or asthma or diabetes, or other physical illnesses in favor of focusing on the needs of people who catch a cold. It just would not happen. When we focus on mental health to the exclusion of mental illness, or give into a stigmatized belief system about those who live with mental illness, everyone loses. It is imperative that we examine why we use the language that we do, why some of the most popular turns of phrase nowadays are describing things as being crazy or insane. This is not a habit that normalizes acceptance of people who live with mental illness. It is equating the idea that people with mental illness are somehow problematic, they're somehow dangerous, and are somehow deserving to be called out for it. That is absolutely, unquestionably not the case. So this false equivalence can cause harm when we allow ourselves to focus on mental health to the exclusion of mental illness. Now, our second learning objective for this session is to examine the prevalence and impact of mental illness on children and on teenagers. So, what does the research show us? The research shows that 50% of mental illness begins before the age of 14. 1 in 5 children, that is 20% of children ages 3 to 17, have a diagnosed mental, emotional, or behavioral disorder. That actually comes out to, if you stop to think about it, in a typical public school classroom in elementary school with, say, 25 or 30 children in it, 1 in 5 means that there are going to be 5 or 6 kids in every single classroom who have a diagnosable mental, emotional, or behavioral disorder. This is a large swath of our population, and these people deserve respect, accommodation, and support. Now, there are 3.4 million children and adolescents who are diagnosed with major depression in the United States. Between 2016 and 2020, the number of children ages 3 to 17 diagnosed with depression grew by 27%. This is not a temporary depression associated with grief, loss, changing schools, having to move to a new state. This is major depressive disorder, a biologically based mental illness diagnosable through the DSM. Estimates go on to say that roughly 1/3 of children and teens who are diagnosed with major depression may actually be misdiagnosed and have instead early onset childhood bipolar disorder. In 2018 to 2019, 15% of the adolescents aged 12 to 17 years experienced a major depressive episode. 37% had persistent feelings of sadness or hopelessness, and nearly 20%, again, 1 in 5, reported that they seriously considered suicide. In adolescent girls aged 12 to 17, there has been a sharp and sustained increase in depression cases since 2009. And mental illnesses commonly co-occur, meaning that people and children can have more than one mental illness at a time. In 2018 to 2019, among children with a current mental health condition, more than 1 in 3, or 37% of them, had, in fact, 2 or more conditions. The research goes on to show some troubling trends in terms of access to treatment. Among adolescents aged 12 to 17, the percentage who received mental health services in a specialty mental health setting, such as an inpatient or outpatient clinical setting, increased from 11.8% in 2002 to 16.7% 17 years later in 2019. Over that same period, the percentage who received mental health services in a general medical setting also increased from 2.7% to 3.7%. And the percentage who received mental health services in an educational setting, such as through a guidance counselor, school counselor, or school psychologist, went up from 12.1% in 2009 to 15.4% in 2019. These statistics are part of what we point to when we talk about a mental health epidemic. Now, I said this access to treatment is problematic. Why? Well, because the average treatment onset delay in this country is a staggering 10 years. That means from the moment a family says, my child needs additional help, until they get an accurate diagnosis and effective treatment, roughly 10 years go by. Now, that is an average. Of course, some people are able to achieve that more quickly. Many people, however, don't even get there within the 10 years. Not a single state in the United States currently possesses an adequate supply of child psychiatrists, and 43 out of 50 states report experiencing a severe shortage. 22% of children living below 100% of the poverty line had a mental or behavioral or developmental disorder diagnosed. Age and poverty level negatively affect the likelihood of children receiving treatment for anxiety disorders, depressive disorders, and other mental illnesses, with younger and less affluent children receiving less treatment. Those younger children are often easily dismissed by providers as experiencing things that are developmentally expected, and our parents are cautioned to wait on treatment in order to see whether or not there is any change that occurs over time. However, this is part of that 10-year treatment delay, and there are ways that a trained clinician can tell the difference between developmentally expected behavior and behavior that is part of a mental illness. The research also shows us that children and adolescents in minority populations, either racially, ethnically, gender-based, experience inequalities in access to care. Suicide rates are nearly twice as high in Black boys aged 5 to 11 as compared to white boys of the same age. Suicide rates are rising more quickly for Black adolescent girls ages 12 to 17 than white adolescent girls. And children identifying as a sexual minority have more than 3 times the increased odds of a suicide attempt compared to their heteronormative peers. Experiencing racism and discrimination has a lasting effect on mental health and on the treatment of mental illness. Now, the issue of treatment access delays has been at the intersection of mental health and psychiatric law for the past few decades. And it has seen a significant increase in attention to mental health jurisprudence and the preservation of human rights in the context of mental health care, access, and treatment. And the authors of the December 2018 article titled Treatment Delayed is Treatment Denied in the Journal of the Academy of Psychiatry and Law state that of considerable concern are those cases in which rote procedural approaches produce unintended consequences for the very persons such maneuvers were designed to protect. Delays may ironically lead to an acute illness becoming chronic, into a single bout of inpatient services being transformed into a lifetime of revolving door psychiatric admissions. It deprives patients of the liberation from illness that is the common goal of all stakeholders. This is absolutely 100% applies to children or teens whose providers decide out of hand that they must have something other than, say, bipolar disorder or schizophrenia or a major mood disorder. Because a lot of people still believe that it simply can't happen in kids, and summarily rejecting the notion that someone could have these disorders in childhood is in fact treatment that is being denied. Similarly, this also applies to minorities who have a decreased access to care and treatment. And the stakes are really, really high for these kids. And so we will use the example of major depression. The increased risks associated with untreated or undertreated depression include suicide, anxiety disorders, substance abuse, heart disease, diabetes, sleep disruptions, chronic pain, premature death, and lower quality of life. Increased risks for untreated or undertreated generalized anxiety disorder are similar. Sleep disruptions, chronic fatigue, irritable bowel syndrome, migraines, chronic pain, social isolation, suicide risk, drug and alcohol abuse, and again, impaired quality of life. Increased risks associated with untreated or undertreated bipolar disorder are a lifetime prevalence rates of substance abuse disorders that are 40% associated with bipolar 1 and 20% associated with bipolar 2. Bipolar has a chronic course of illness and is associated with a markedly elevated premature mortality, often through suicide, with approximately 10 to 30 times higher in bipolar subjects than in the general population, 20% of whom are mostly untreated bipolar disorder subjects who end their life by suicide. 20 to 60% of those with bipolar attempt suicide at least once in their lives, and bipolar disorder has the highest suicide completion rate of any mental illness. Now, with stakes this high, any provider would be foolish not to consider the possibility that these disorders might be occurring in children, especially if those children have a relative, a blood relative, parent, sibling, grandparent, aunt or uncle who also has one of these disorders. It would be like a family that had breast cancer in all of the grandmothers and parents and aunts in the family, only to dismiss the possibility of breast cancer in a teenager based on the fact of age. Now, we're going to move on to our third learning objective, which is to describe best practices for effective treatment. We like to talk about treatment as a three-legged stool. And that three-legged stool is a way to look at mental illness treatment as a holistic approach. Effective treatment, the kind needed to achieve stability and to maintain it while managing a chronic mental illness, requires that it have multiple different approaches working together in a comprehensive way to support the patient. And so the first of the legs of this three-legged treatment stool is medication. The second is therapy, and the third is lifestyle interventions. Now, medication. Not everybody wants to take medication. No one should be forced to take medication that they don't want to take. But for those who do welcome this intervention when necessary, those medications need to be accessible. That means they need to be affordable. That means that they need to be able to have the ability to pay for them, have them covered by insurance, have their pharmacies be able to carry them, not be impacted by shortages and production and distribution interruptions, because these medications are necessary for maintaining their health long term by managing their chronic mental illness. It also means, in the case of significant mental illnesses, that a multi-medication combination is going to be necessary. For illnesses like bipolar disorder, schizophrenia, major depression with psychosis, these illnesses are often treated with medications in combination with one another. But it's also very important that we remember, when we are dealing with this kind of long-term management, that side effects of medication need to be considered, that there needs to be a risk to benefit analysis of every medication that is added. All too frequently, we find that in the system, medications are layered upon one another or changed rapidly, causing patients to experience withdrawal, or they are not given the chance to see if one medication works before adding another. Every medication needs to be handled with care. Every medication addition or removal needs to be done slowly so that the patient has the best chance of determining which medications are actually treating the symptoms that they want and need to have treated. The next essential part of treatment is the psychotherapy. This means that when you're dealing with a chronic mental illness, you want to be working with a provider who understands that chronic mental illness. For example, if you have bipolar disorder, you don't want to go to someone who specializes in managing life after divorce. You want to be working with someone who specializes in bipolar disorder, major mood disorders, such as major depression. You want someone who's going to be able to know what is current in the literature, what current research is telling us, and are not rooted in simply what they learned in school 5, 10, 20, or even 30 years earlier. You want to work with someone who can recognize symptoms of these disorders in children and teens, and who can differentiate involuntary symptoms from behavior, and that can help you as the parent or caregiver differentiate symptoms from behaviors and approach their resolution appropriately. You want to work on finding someone that you have a rapport with, and a provider that focuses on rapport building, not skill development. Because again, skill development is not something most people with mental illnesses have difficulty learning. What they have difficulty with is applying it in moments of dysregulation when involuntary symptoms are controlling how they feel and perceive their environment. So, rapport building for ongoing long term relationships between clients and their providers is what is most important. You also want a provider who knows when to use traditional therapeutic interventions and when to try something new, when to use the tried and true conservative approach, and when to think outside of the box. Family therapy and individual therapy for parents and siblings is also a really important part of the therapeutic process. Now, this third leg of the stool, lifestyle interventions, these can be anything from light therapy to cooling strategies and body temperature regulation to metabolic therapies involving sleep routines, food plans, and exercise. Metabolic health is the same thing as mental health. When we look at the connection that exists between our minds and our bodies, the scientific evidence suggests that mental illness can be rooted in systemic metabolic dysfunction affecting the brain. Neuroscience shows us that brain metabolism is impaired in people with mental disorders and mental illnesses, and that improving that brain metabolism actually reduces symptoms. Metabolic psychiatry is a new field that is rapidly emerging and is helping to put symptoms of mental illness into remission using metabolic interventions. And those strategies are things like ketogenic therapy that is emerging as a promising new treatment for psychiatric disorders, for improved brain health, and for overall improved quality of life. You can learn more about metabolic treatments for mental illness through these sources. We have the book Change Your Diet, Change Your Mind by Dr. Georgia Ede, Brain Energy by Dr. Chris Palmer. We have the Modified Keto Cookbook that was written by Beth Zupek-Kania, a registered dietitian and a member of the board of the Charlie Foundation for Ketogenic Therapies and Epilepsy Treatment. Denise Potter, dietitian with advanced ketogenic therapies. You can find her website online with tremendous resources for families as well as providers on ketogenic therapies for mental health treatments. Metabolic Mind, which is an organization devoted to the promotion of information around metabolic impacts associated with mental illness and metabolic treatments. And we also have our own CMHRC ketogenic therapy program, which has two components. One is a longitudinal research study that we are working on to see the effects of ketogenic therapy in children, as well as a standalone program open to anyone who would like to try this metabolic intervention. Now we are on to our final learning objective. Our final learning objective is to explain a new, more effective approach to parenting that supports parents and caregivers of children who are living with mental illness. So this new approach to parenting is based on a turning away of traditional models that focus on things like rewards, punishments, consequences, which is just a new fancy term for punishments. And with this approach, we developed a way for parents of non-neurotypical children, of children who would be described as neurodivergent, to find a way to parent these kids in a way that respects the fact that what they are experiencing oftentimes are involuntary symptoms over which they have no control. And so this parenting model was developed in collaboration between children, parents of children who live with mental illness, mental health providers who treat children who live with mental illness, and adults who live with mental illness and did so as children. So they have that lived experience. And the fundamental principles of palliative parenting are that in palliative parenting, we stop blaming children and their parents for their mental illness. We reject formulaic strategies that suggest that kids with mental illness somehow need to be fixed, and we accept and respect them as the individuals that they are, with the skills and strengths that they have, as well as with the limitations that they have and that they face in a world that often doesn't recognize that they're living with involuntary symptoms. In this model, the focus isn't to change the child's behavior through the imposition of consequences or token economies where we are offering rewards and bartering and negotiating. Instead, we change the parent's perspective, their thoughts, their feelings about mental illness and about the fact that their child lives with a mental illness, which means that with that shift, parents are using the way that they're interacting with their children, their relationships with their children, as the tool to create positive change and improve quality of life. Palliative parenting empowers parents to understand the symptoms of mental illness and their impact, to see those symptoms as involuntary and not intentional behaviors, and to address symptoms in ways that promote positive change while validating the child's lived experience. The three pillars of palliative parenting are acceptance, respect, and community. In acceptance, we accept the fact that our children have an illness, and we parent differently because their needs are different. We let go of preconceived expectations for our children, and we can protect our children from the pain of their illness, but we can make their daily lives a little bit better despite the fact that they will experience pain and discomfort from it. And that when we as parents make mistakes, we forgive ourselves. The pillar of respect in palliative parenting is focusing on our children as human beings first, with their own journeys, that our children's symptoms are not willful or deliberate, and that we respond to those symptoms with empathy and compassion first. We model and teach self-care to our children so they can learn that as they grow and develop into adulthood, and we strive for the highest possible quality of life. And our third pillar of palliative parenting is community, that our children make positive contributions to the world, that we can advocate for awareness, acceptance, and accommodation in their communities and at the world at large, that we can be honest about our children's strengths and their weaknesses, that we can facilitate collaboration among our child's support systems, and that we share strength, knowledge, and hope within our community. These principles are not just made up out of whole cloth. These principles are rooted in science. They are rooted in the research that shows that people improve, mental health and mental illness improve when they can come together in acceptance and understanding and in community, because these actions break down the dangerous impact of isolation. Isolation, and far too many people living with mental illness live in isolation, partly because of stigma, partly because of lack of resources, and partly because of a simple lack of understanding of what many of those disorders mean. So isolation is dangerous because it creates self-doubt, it causes guilt, it perpetuates negativity, burnout, and self-harm. This is a quote from a parent who found community in the CMHRC family. This parent said, "My children live with trauma, autism, ADHD, bipolar, and anxiety, which is so isolating for us. On the really hard days, CMHRC gives us the community of parents I've been longing for. Socially and emotionally, CMHRC is a lifeline, sharing knowledge, compassion, and grace, the dose of humor that I need to continue living this life fully. This sentiment does not and is not about CMHRC alone. It is about the power of community and what can be done when people come together to break down stigma, to promote understanding, and to provide one another with the support, compassion, acceptance, and respect that they themselves want to receive from others. When we are able to do this, to break down stigma, provide services, and be able to understand fundamentally what it is like for folks who live with mental illness and provide them with the dignity that they deserve, then we know that no one is alone. You are not alone, and we are here to help. So here are the works that were cited and were used to build this presentation today. As you can see, there were quite a few. For any additional information, support, services, professional consultation, anything that you may need as a family or a practitioner, please feel free to reach out to us at admin@cmhrc.org or to check out our website at cmhrc.org, where we have extensive information on all of our programs and services, and find a way that you can get involved with this community so that we can help you get the services and treatment that you need. Thank you for attending. What I'm going to do now is I'm going to turn off this screen share and invite my colleague, Angela, to come on and share with me any questions that arose during the session in the Q&A and through the chat.
Oh, thank you, Elizabeth. That was incredible information. There was a comment that said that they were finding it so useful and wanted to know about a recording. And so I just wanted to let everyone know that a recording will be available on our YouTube channel, probably late next week, early next week, once it's edited. So everyone has that information and can go back and get all of the great details of this session. I wanted to start back talking about the 10-year treatment delay. Quite honestly, I think all of us human beings can say how unacceptable that is, that it's truly a childhood lost. And so I would just like to hear from you in such that what can families do to help decrease that delay, especially with this shortage of appropriate providers? What steps could they be taking to help get the appropriate treatment and diagnosis more quickly than that 10 years?
That's an excellent question. And one of the things that the answer sort of points to is many of the flaws in our system, right? We're stuck in this position where obviously mental health providers deserve to be paid for the work that they do, just the way anyone deserves to be paid for the work that they do. But very often, insurance companies are creating problems for providers to be able to get reimbursed for the services that they provide. And so many providers are opting out of insurance systems. And what that means is that now seeking care is becoming harder and harder because there are fewer people in the insurance system as providers who can be seen, which means there are longer waiting lists, and there are challenges geographically to being able to get to where the practicing providers are who are in that network. And it removes from parents the option of having access to people for whom they would only be paying a copay. And so one of the things that I absolutely hate saying, but turns out to be true a lot of the time, is it's easier oftentimes to find care outside of the existing system. The problem with that is that becomes a major obstacle for anyone who doesn't have the financial means to pay $150 to $375 an hour for their psychiatric care. So one of the things that we really advocate strongly at CMHRC as a result of this reality is the use of that third leg of the stool, right? So maybe you can't get in to see a therapist. Maybe you only have a very limited options associated with medication because the only provider that you can get to write a prescription is the pediatrician, and they feel as though they don't have the breadth of knowledge to treat a serious mental illness. Well, by leaning on that third leg and really implementing a lot of low risk, high reward at home interventions with everything from those metabolic therapies, uh, sun exposure, light exposure, exercise, diet, nutrition, all of these things can make a really big impact on improving symptoms and reducing the dependence on that portion of the system that right now is wildly uh, overrun and unable to keep up. So I always suggest to people that they start with their insurance, they make decisions about what is and is not possible for them, and to reach out for support around programs to educate your providers, and as well around things such as those at home interventions that may make a real difference in terms of a child and a family's ability to improve their quality of life.
I think that's great information, and it's really important to know that there are options out there that you can implement into your home without needing a doctor's note per se. And I think it also speaks to the importance that you talked about at the end with isolation. These lifestyle interventions, implementing them are going to be easier when the people around you understand what's going on, when the people around you appreciate what you're trying to implement, when they recognize that it's going to be beneficial. And so I think all of those pieces fit together really nicely. On a flip coin, I would like to talk about for a moment, you mentioned several times throughout the session involuntary behaviors versus symptoms. And I think that that's something when you're living with this and you're watching it, you're looking at it like, wow, I know they can't help that. That's not on purpose. But how do you differentiate between involuntary symptoms and behaviors? And then how do you advocate for your child to other people who might not be as knowledgeable or understanding?
It's an extremely important distinction that you're highlighting, and an extremely important part of parenting children who live with mental illness. All children have tantrums. We've all, any parent knows that their toddler may have a meltdown because they gave them their juice in a blue cup instead of the red cup, and that's just how it all went down. So mood fluctuations are normal. They're normal in toddlers, they're normal in adults. Like we all have moods. But and our moods aren't necessarily anything that we have control over, but when they're sort of falling within the realm of sort of expected normal human experience, we can all empathize. It's when things become exaggerated, extreme, they become more difficult for other people to understand. And so they're looking at it and they're thinking, well, this person must be experiencing something that's normal, but the way they're reacting to it is ridiculous. And so I'm going to make them stop reacting to it that way. But that misses the fundamental understanding of what a mental illness is, which is that it is an involuntary symptom. It is not being triggered by the environment. It is not the same thing as what anybody else would experience. It is a event that has occurred without an antecedent, without a notable trigger, that is causing a major disruption in the person's ability to think, to function, to feel, to interact with other people. And when a person is having that, it is cruel to attribute to it intentionality. It would be as though if I had a broken leg and someone told me that I needed to walk on it, that I wasn't allowed to be weak and sit down, that I needed to get up and walk because that's what everybody else does. No, a mental illness is a condition that needs to be managed. It needs interventions, it needs accommodation, it needs support in order to help that person function at the best of their capacity, which incidentally will vary from day to day. So it's really important for teachers, coaches, siblings, grandparents, aunts and uncles, you name it. If you have a child in your life somewhere, it's really important to understand that when that child who has a mental illness is, quote, behaving in a way that you or someone else doesn't like, that chances are it's actually a symptom over which they have no control. And when they're doing it, it's a signal to those around them that they need help, they need support in that moment, not criticism and not dictates and ultimatums.
It really is such an important distinction, and I think it changes the way that um, we interact with our children when those things are happening. It changes the way other people interact with our children, which is a nice segue into the palliative parenting approach that you spoke about. Utilizing that approach really is a paradigm shift in parenting, in how you're thinking and how you're approaching mental illness in your children's actions. But my question is, because not everyone understands palliative parenting, not everyone understands mental illness in children, how does one take the information that they learn and embrace in palliative parenting and impart that to the other people who are also part of their child's life? Um, because I think it can be frustrating to be in this space and understanding and approaching it in an appropriate way that's causing growth and healing. And then an hour later, you're in a different space with other people who do the exact opposite of what needs to be done. So, how do you walk that line and impart that knowledge?
It's tricky and it goes back to community. You know, whether your community is part of CMHRC or whether it's part of your church or whether it's part of your Cub Scout pack or whether it's part of your family, extended family unit, having community around you that understands what you're doing and what you're trying to do is extremely important because it bolsters you, it buoys you, it gives you that sense of hope and connection that's necessary to do those hard things when you have to go out there in the world and explain over and over and over again that no, my child who is struggling right now in the grocery store because I'm not willing to buy this, 30-pound bag of chocolate for them, isn't being a brat. They're having a symptom. We wouldn't expect a child who had a seizure and fell on the floor and knocked over a pile of cans in the grocery store to pick them up after the seizure was over and put them back and apologize to the store manager for having knocked them over. And so it's about changing our expectations, but also about having to just repeatedly go up to and face other people and say, thank you for your concern, but I have this under my watch, and I'm going to take care of my child. And to some degree, it is unquestionably exhausting. But to some degree, if we can look at it as a gift to our community, that every time we explain this to someone else, we are making it easy for the next person who comes along. That makes it easier. And we can also look at it from the standpoint of, as a parent, there are things that we don't expect our children to do immediately. We don't tell our child, okay, you're 14 months old now, it's time to walk. Go ahead, walk. Teach them how to walk. We let them fall down. We pick them up. We comfort them. We give them the process of learning and we encourage them along the way. We can apply this to this massive community education that has to take place. That, parents say, how many times as a parent do we prompt our young children, don't forget to say thank you, don't forget to say please. We do it with neutrality because we know that's how they're going to adopt the behaviors. We can do the same thing with our community. To just repeatedly, calmly, with a neutral tone, say, this is the result of an illness. This is the result of a symptom. We're going to create an understanding that what they're doing isn't on purpose. It's not voluntary. It's not designed to push your buttons. Even if it is, that's on you. That's not on them. They're having the symptom. There's one parent in our community who talks about the fact that when their child becomes symptomatic, they imagine that their child has the flu. And the degree to which you would wrap that child up, you would care for them, you would pamper them, you would meet all of their needs because they have the flu, is the same way that we advocate approaching those moments when our children are dysregulated because of a mental illness. Is it easy to do? No. Does it take a toll? Yes. And that's where community comes in. It is so, so important to have people who understand, who live it too, who you can have that sense of community and shared experience with.
Approaching situations with that mindset, I think also decreases the stigma around it, right? When we're not overly apologizing, we're not making excuses. We're saying this is from an illness. This is what's happening. It's under control. I think it neutralizes the situation and allows people to see that it doesn't have to be dangerous. It doesn't have to be, the negative connotations that often come with mental illness. And so I think that that's an important piece of it as well. As we close out and on this topic, there's one more comment that I would love your insight on. Someone mentioned that they love the palliative parenting approach. It avoids blaming the parent, but they feel that it does not address parents who feel triggered by their own undiagnosed mental health illness. So they're learning about their child's mental illness, but theirs is undiagnosed and maybe even unstable. How do we balance that?
It's so interesting that you bring that up. So I want to thank the person who added that comment. When we go through the palliative parenting approach, one of the things that we're doing is not just learning how to meet our children with compassion, but it is also about meeting ourselves with compassion and looking at the things that brought us to where we are. We all have our challenging experiences. People have trauma, people have mental illness, people have all sorts of things in their pasts. And with palliative parenting, the first thing that we do is we address the issues associated with grief. Grief that our child may be turning out to be and experience things in life that are different than what we were expecting, that are different than what we experienced. There's also grief that we're not getting to be the kind of parent that we had imagined, that we are looking back on our own childhoods and thinking, well, I needed this and I didn't get it. Or I'm having my own trouble now. The fundamental piece of palliative parenting comes down to the idea that whether your child is 5 or 45, whether you have a mental illness or not, what you are fundamentally doing is figuring out a way to accept yourself and your child and your parents, to respect yourself, your child, and maybe your parents, and to find community for all of those people. So when we have, as the adult, the parent, we have our own mental illness, it's really important that we show ourselves the same compassion, that we recognize that sometimes what we're living with is an involuntary symptom and that it's causing challenges in how we're parenting. Palliative parenting believes in taking care of yourself as a parent. So getting your own mental health challenges, your own mental illnesses diagnosed and treated properly is part of being a good parent. And so we encourage that. We encourage that you treat yourself with the same kind of holistic dignity and respect that you're going to show to your child. So it's tricky, but knowing what your own limitations are, knowing when you need to step out, knowing when you need to let somebody else in to help, when you need to knowing when to share those parenting responsibilities, that's a really important part of it. And it comes with that paradigm shift that you're talking about. When we stop thinking about mental illness as a defect that needs to be fixed, and we think about mental illness as being like a physical illness that just needs to be managed over time, then we can let go of a lot of the things that cause us obstacles in that building of relationships and improving the quality of life.
This was all really incredible information. And I think at the bottom line, it comes down to recognizing that mental illness is manageable, and mental illness is even more manageable with community surrounding you, and helping you break that stigma, the negative stigma that is all around society. So I really appreciate everything that you presented today. I think that it's incredible information for us to take and get out to other people as well.